Welcome to the deep dive. Today we're going to try and crack open a really formidable clinical handbook. It's called Practical Psychopharmacology.
And it's not just another textbook, which I think is the key point. It's really designed as a structured guide for prescribers.
Right. So our mission here is to pull out the most crucial practical knowledge for you, the listener. Whether you're a med student, a young professional, or, just really motivated to learn this field.
And this book is so valuable because it really addresses a huge gap in medical education.
A gap? What do you mean?
Well, when you look at standard pharmacology training, you get bogged down in all this molecular detail.
Which is interesting, but maybe not what you need on a Tuesday afternoon in the clinic.
Exactly. Or you get these really generalized algorithms that don't help you at all with a complex patient.
So it's either way too deep or way too shallow. This book tries to solve that by staging the expertise. Is that right? It kind of recognizes you don't become an expert overnight.
Precisely. It sets up what we can call 3 distinct levels of learning. The first level, which is section 1 in every chapter, is really just for the beginning prescriber.
And it's all about speed and standard of care.
Purely. It's about fast, reasonable decisions.
So what's the guiding question for that section 1 novice?
The question is basically, what do I really need to know right now to make a good diagnosis and start an approved, evidence-based monotherapy?
Monotherapy meaning one drug.
One drug. It's about using screeners, applying the DSM-5, and just picking from that finite list of proven FDA-approved medications for first-line treatment.
Okay, so that's the rapid recognition phase. Identify symptoms, pick a single approved drug. But clinical practice is rarely that clean, right? What about the more advanced clinicians, the ones dealing with really tough cases?
And that's where section 2 becomes absolutely essential. This is for, the mid-level clinician or anyone dealing with the treatment-resistant patient. You have to move beyond the basic guidelines.
And section 2 brings in the nuance.
It brings in all the nuance. Basic science like genetics, neuroimaging, and it focuses heavily on managing high comorbidity.
Which is when a patient has multiple conditions at once, like depression and anxiety.
Exactly, like major depressive disorder, MDD, alongside generalized anxiety disorder, or GAD.
I see. So the big takeaway for you listening is that this handbook isn't just a reference. It's more like a training path.
It is a roadmap.
It lets you pull the what do I do first answer, but at the same time, it gives you that path to become a more knowledgeably aggressive prescriber for those complex cases.
Absolutely. The goal is efficient decision-making from day one, while always having that guide on how to pivot when the first drug doesn't work.
Okay, let's lay the foundation then. Before we even get to drugs, we have to talk about the cornerstone of all of this, which is diagnosis.
Right. The sources are so clear on this. Psychotropic meds only work if the diagnosis is accurate in the first place.
And the biggest enemy there is symptom overlap.
It's the greatest enemy. Think about something like inattention or fatigue, poor concentration.
They're not specific to one thing.
Not at all. Inattention is a core feature of ADHD, but it's also common in MDD, PTSD, and GAD.
That sounds like something that would take way more than a typical 15-minute appointment to sort out.
Yeah.
How does the book suggest you get that rigor, but quickly?
The guidance is to pair simple, fast screening questions with the really systematic approach of the DSM-5.
So you start broad.
You start with high-yield questions. For ADHD, it might just be, do you often make careless mistakes? Or is it hard for you to sit still?
And if they say yes.
Then you move to the full DSM-5 criteria to confirm, duration, impairment, all of that.
And crucially, the sources really push for using standardized rating scales. They compare them to, clinical vital signs.
They are vital signs, like using a blood pressure cuff for hypertension or checking blood glucose for a diabetic.
Why are they so essential?
Because they give you a reliable, objective score. They track severity and outcomes over time because you're asking the exact same questions in the exact same way at every single visit.
So it takes the subjectivity out of it.
Completely. And it lets the clinician review the patient's answers before the session and focus immediately on the symptoms they marked yes to.
Okay, let's play devil's advocate for a second. I hear this a lot from clinicians. The resistance is that scales are, copyrighted or they're just too time-consuming.
That is a total myth that needs busting. The source material is very clear that for almost every DSM-5 disorder, there are excellent, validated public domain options.
Free and efficient.
Free and efficient. For example, the Adult ADHD Self-Report Scale, the ASRS, is public domain. It takes 1 to 2 minutes, and if you score 4 or more in the shaded areas, that's highly suggestive of the diagnosis.
What about for anxiety?
Same thing.
Yeah.
You have the GAD-7, the Generalized Anxiety Disorder 7, free, short, public domain. A score of 10 or more suggests moderate anxiety. You can use these in the waiting room. It costs the clinician basically no time and makes follow-up so much more efficient.
Okay, that efficiency is huge. So now we've nailed the diagnosis and the measurement. Let's get into the core treatment paradigm. The basic reflex for a novice is pretty clear. Symptoms, approved drug, start low, go slow, and assess.
Right.
Let's apply that monotherapy reflex to adult ADHD.
For ADHD, your first-line agents are stimulants. That's either amphetamines or methylphenidates.
And the book emphasizes a key clinical detail here.
Yes. The preference for slow-release, once-daily products. This is vital.
Why?
2 reasons. 1, it improves compliance. The patient just takes 1 pill. But more importantly, it theoretically lowers the addiction risk.
Okay, so why does extended release lower the addiction risk?
It's about the absorption. A gradual absorption gives you these very consistent blood levels all day. There's a minimal, if any, intoxicating effect. You avoid that rapid rush or mood boost that you see with high-risk drugs.
The patient just feels more functional, not high.
Exactly. Not intoxicated or euphoric, just functionally better.
All right, let's get a little technical here for a second. There's a pharmacology nugget about what makes these 2 classes of stimulants different. Let's talk dopamine, or DA, and norepinephrine, NE.
Okay. So both amphetamine and methylphenidate work by blocking the reuptake of both DA and NE, so more of it stays in the synapse.
But amphetamines are different.
They are. They go a step further. They don't just block the dopamine reuptake pump, they also reverse it.
Reverse the pump. That sounds pretty aggressive.
It is. Reversing it means the neuron actively starts pumping dopamine out into the synapse, so you get a much greater overall release of dopamine compared to methylphenidate, which only blocks the reuptake.
And that explains why some patients respond better to one than the other.
It's a key reason, yes.
But despite how effective they are, the book has some very clear cautions. When should stimulants not be the first choice?
You should think of them as second or third line if a patient has a history of addiction, any significant cardiac issues, or an eating disorder like anorexia.
Because the risks are just too high.
The risks of addiction, arrhythmia, and weight loss are real. You have to weigh the superior effectiveness of the stimulant against the safer profile of a less effective, non-addictive medication.
That is a perfect transition to advanced prescribing, which is where Section 2 really comes into play. Let's talk about off-label use.
Right.
Because I think a lot of new prescribers see off-label prescribing as risky, maybe even illegal.
And it's so important to clarify that right away. Off-label prescribing is not experimental and it's not illegal.
It's just repurposing a drug.
It's simply repurposing a medication that's FDA approved for one thing to treat something else. A great example is using the antidepressant bupropion for ADHD, or using the ADHD med lisdexamfetamine for binge eating disorder. Both are totally accepted, evidence-based practices.
But the key here is justification, right? You have to document everything. You can't just do it on hunch.
Absolutely not. You have to document your rationale. Usually it's because all the approved treatments have failed, or the patient's other conditions make the approved drugs unsafe.
And your choice has to be backed by science.
It has to be supported by solid neuroscience and pharmacodynamic theory. You need to be able to explain why you believe that drug's mechanism is going to help that patient's specific symptoms. This is where Section 2's focus on neurobiology is just so critical.
And speaking of neurobiology, the handbook has this fantastic tip about using that knowledge to improve rapport with the patient.
Yes. This is so effective. Instead of just handing over a prescription, you take a couple of minutes to explain the neurobiology of the disorder itself.
So for an ADHD patient,
You might explain that the disorder involves underfunctioning areas of the brain where dopamine is low, and that's what leads to problems with attention and motivation.
and then you connect that directly back to the medication.
Exactly. You explain how the stimulant restores that activity, giving those brain regions the dose of dopamine they need to function normally.
That seems like it would create a real alliance.
It immediately does. The clinician becomes a de facto teacher and educator. It improves confidence, compliance, and even helps them tolerate mild initial side effects. The patient feels understood on a scientific level.
Okay, let's dig into Section 3 then, handling comorbidity and treatment resistance. We'll start with major depressive disorder that just isn't getting better.
Right, moving past that simple monotherapy reflex.
What's the guiding principle here?
It's about being sequential and aggressive, but the key is to avoid using successive drugs that have the same primary mechanism if the first one fails to give you at least, say, 20% improvement.
So if one SSRI fails, you don't just try another SSRI.
Please don't,
Yeah.
especially not a third one. You have to switch mechanisms.
And that same sophistication applies when you start combining drugs, right?
Yeah.
Polypharmacy. What's the difference between good polypharmacy and just, stacking drugs blindly?
Good polypharmacy is about combining drugs with different complementary mechanisms. A classic example is adding a noradrenergic tricyclic, a TCA like desipramine, to an SSRI.
Okay, so the SSRI is hitting serotonin.
Primarily. And the TCA at a low dose is primarily blocking norepinephrine reuptake.
So by combining them, you're essentially creating an SNRI, a serotonin and norepinephrine reuptake inhibitor, but with two different pills.
Precisely. And this is better because you avoid duplicating the same action. If you stacked two drugs that both hammered the serotonin transporter, you just dramatically increase your risk of serotonin syndrome for no good reason.
You maximize efficacy while minimizing that mechanistic risk.
That's the art of it.
Okay, let's shift to bipolar disorder. The book notes it's incredibly heritable, like 60 to 85%, and mania is the hallmark.
And there is a massive clinical caution here when it comes to treating the depression side of it.
Which is,
The central danger is what's called unopposed antidepressant use in bipolar I disorder. That means using an antidepressant without also using a mood stabilizer or an anti-manic agent.
what happens when the antidepressant is unopposed?
You risk inducing mania
Hmm.
or mixed states or rapid cycling. You can seriously destabilize the patient.
So a patient comes in looking depressed, you give them an SSRI?
And you can flip them into a full-blown manic episode if you haven't screened carefully for bipolar. Antidepressants, if you use them at all in bipolar depression, have to be started after or at the same time as an effective anti-manic drug.
So what is the gold standard for treating bipolar depression?
The gold standard relies heavily on second-generation antipsychotics, the SGAs. The approved options are things like the olanzapine-fluoxetine combo, quetiapine, and lurasidone.
And why them?
Because they have strong anti-manic properties while also having approved antidepressant effects at certain doses. They treat both poles of the illness.
Okay, lastly, insomnia. The book frames it as often being a residual symptom of something else, like MBD or mania or a substance use disorder.
Right, so when insomnia is comorbid, the general rule is to treat the primary disorder aggressively. But the advanced strategy is about being clever with your drug choice.
How so?
If you have a patient with MDD and really bad insomnia, you might pick a psychotropic for the MDD specifically because you know it has a sedating side effect.
So you're leveraging the side effect therapeutically. Give me an example.
You might choose mirtazapine for the depression because it's a potent H1 receptor antagonist.
Which causes sedation.
A lot of sedation.
Yeah.
Or you might use quetiapine for mania and leverage its sedating properties. It helps you avoid adding a separate sleeping pill, which streamlines the whole regimen.
And when substance abuse is in the picture, avoiding addiction is everything.
Absolutely. When addiction is comorbid, you have to prioritize non-addictive off-label approaches over the BZRAs, the benzodiazepine receptor agonists. So you look at things like clonidine, trazodone, or even a low dose of quetiapine to manage sleep without introducing any dependency risk.
This has really mapped out the whole spectrum, from the simple diagnosis all the way to this very intricate neurobiology-informed polypharmacy.
It really has.
The structured approach to this handbook, moving you from Section 1's basic practice to Section 2's more aggressive strategies, it really does seem like an accelerator for your professional growth.
I think what becomes so clear is that mastery is really about understanding the unique neuroreceptor profiles of every single drug. That knowledge lets you treat multiple complex conditions with fewer, more effective agents.
Instead of just giving each diagnosis its own pill.
Right. You stop just matching a pill to a label.
So, circling back to application, what's the final mandate for a clinician who's dealing with those really complex treatment-resistant cases?
The focus has to shift. You have to move away from the broad diagnosis and onto a clear, measurable target symptom.
Especially in things like neurocognitive disorders or borderline personality disorder.
Especially then. You have to define what's causing the distress. Is it impulsivity? Is it apathy? Is it agitation? And then you measure the response to the treatment that targets that specific thing. Don't blindly treat the diagnosis. Treat the patient's measurable symptoms.
That is a very powerful final directive. Before we wrap up, let's leave you with a quick review exercise that kind of pulls all this together.
Okay, here's the scenario. You're managing a patient who is newly diagnosed with major depressive disorder, MDD, and they also report significant insomnia.
So, using the principle of using a single drug to treat comorbidity, name one FDA-approved antidepressant with known sedating properties.
And then explain the specific receptor mechanism that gives you that therapeutic side effect.
Think about the different receptor profiles we talked about, especially the ones related to histamine or adrenaline blockage. That should get you there. We really appreciate you joining us for this deep dive into applied psychopharmacology.
And we hope this structure helps you accelerate your own expertise.